Our next speaker is Dr. Vijaya Kolachalama, who is an associate professor in the departments of medicine and computer science at Boston University. He's also one of the founding members of the Faculty of Computing and Data Sciences at BU. He obtained a BS in aerospace engineering from the Indian Institute of Technology and a PhD in mechanical engineering from the University of Southampton in the UK. Before joining BU, he was a principal member of the technical staff at Draper Laboratory and a postdoctoral fellow at MIT, where he also served as an ARISE fellow at the US Food and Drug Administration. His laboratory develops methods at the intersection of AI and human health with a focus on neurodegenerative conditions. He has co-authored more than 100 papers, many of which are published in high-tier journals, including as senior author in Brain, Nature Medicine, and Nature Communication. His research has been supported by grants for multiple institutes at NIH, including the NIA, NCI, NIDDK, NHLBI, and NINDS, as well as from the American Heart Association, Gates Ventures, and Johnson & Johnson Enterprise Innovation. Dr. Kolachalama is a senior member of IEEE, a Toffler Scholar in Neuroscience, and a Fellow of the American Heart Association. He actively works with industry and investment communities to translate software technologies to the clinic. It's a pleasure to welcome Vijaya, my BU and departmental colleague, to present some of his exciting work. Vijaya, the floor is yours.
Thank you, Lindsay, and thank you to all the organizers for giving me this opportunity. I was reading the announcement and that said internationally reputed scholars. I don't think I am one of them. I am definitely international, but I think all the others definitely have more reputation than I do. But I'm here today to share some of the outcomes of the work our lab has been pursuing over the past 7 to 8 years. But before I begin, I have a quick disclaimer. Every single slide you're about to see, the design, the flow, the content, and even the illustrations pulled from our papers were all created entirely by AI. I probably spent maybe about 5-10 minutes reviewing and making some minor edits here. The reason I'm mentioning this is because we are living in a moment where every one of us has to think on how we actually conduct research, especially on the computational side. We are getting better at confronting this new reality. Our approach has been to mainly ask some sharper questions, but our goal has been mainly to think about translational impact today. So the stuff that I'm going to show you today is mainly about how we are able to just not work on research, but also build tools that are now being translated into the clinic. So to explain why this matters, let me contrast two very different worlds. Most traditional epidemiological or hypothesis-driven studies, they often begin with a measurement. For example, hippocampal atrophy on MRI or p-tau 217, which is very recent in blood. And then we sort of tested its association across many different clinical outcomes. Researchers, depending on their resources and expertise, they become experts in generating these association studies. These efforts are almost always conducted at large academic medical centers. But the reality is that collectively they see fewer than 10% of patients in this country and maybe around the world. In contrast, more than 90% of patients are seen in private practices, community clinics, and by general neurologists or even primary care physicians. So over the past 6 to 9 months or so, as part of NSF-funded iCore project, I actually had a chance to speak with more than 100 practicing neurologists across the country using different surveys, online and in person. And what I heard basically flipped the diagnostic challenge on its head. So basically, a patient walks into the office with a family member after driving a long distance. The clinician almost always have limited time and resources. So their immediate question is not, should I order this fancy blood test and see if p-tau 217 is elevated or something like that, but rather, I think their question is, how can I best diagnose this person's cognitive status right now, whether it's normal MCI or dementia, and if there is impairment, what is causing it? Is it Alzheimer's? Is it Parkinson's, depression, vitamin deficiency, or likely some combination like mixed dementia? Using specifically the tools that I have available today. I think that's the key point. And that's the real world problem that I think we've been trying to solve using AI. So everything I will show you today is directed towards building those scalable, hopefully accurate, and somewhat practical AI solutions that can support clinicians in exactly these kinds of everyday diagnostic challenges. So these are the tools that in many cases already perform at or above the level of an expert clinician. So my talk is divided into two themes. The first one is related to the development of this multimodal AI system that can take every single piece of information that's actually available, including patient level history, demographics, medications, physical and neurological exam findings, biomarker data, digital if available, neuroimaging, to provide a comprehensive report that provides details on the person's cognitive status, including all the etiologies that might be driving that cognitive impairment. This study was a work over a period of many years. It used tens of thousands of cases from multiple different cohorts, international cohorts for model development. The second part is kind of focused on this multimodal neuroimaging language model, which takes any combination of brain MRI sequences to create a full radiology report, including a summary of findings and an overall impression. The study actually used over 850,000 MRI sequences obtained from many international cohorts for model development. The first is about this EHR integrated AI for dementia care. So obviously, when we started to work on it, our goals were not that big. We actually learned what the kind of questions we were supposed to ask. But when we started doing this, I think the first question we thought was, okay, what if we come up with a multimodal AI framework, which just simply takes an MRI scan of a person, as well as some basic demographics data, to see if we can come up with a way to differentiate between those who have perhaps Alzheimer's disease, as pointed by like hippocampal atrophy on the brain, versus those who do not have any disease. And that kind of led to our idea of creating this interpretable AI framework, which I think some of the other speakers also talked about, which is about how do you not only build an accurate framework to distinguish between, let's say, two different labels, but also go back into the input data to identify specific aspects of the inputs that might influence directly the output. And that was a few years ago during the COVID time. But then during the process of review, one of the reviewers asked us a question as to, nobody actually does these kinds of simple binary classifications in the real world. The challenges, the questions that are asked in the real world are more challenging or more comprehensive, where a patient again like walks in. I think the question is more about understanding whether the patient has healthy cognition, MCI, or dementia. And if the person has some cognitive impairment, then is it because of Alzheimer's or is it because of some other etiology? So then we sort of expanded our study to create, again, another multimodal framework to ask that cascaded question, which was first, given all the set of inputs, can you identify if the person has normal cognition, MCI, or dementia? But if the person has this likely dementia or MCI, then is it because of Alzheimer's or some other non-Alzheimer's pathology? And we also, with the help of clinicians, we compared our model predictions with the clinician performance, and we showed that our model kind of really meets up to the standard of an average neurologist in terms of assessing these conditions. And then after we started to work along those lines of thinking about multimodal frameworks, one of the big questions that I think we were asked was clearly the most common, at least in the published papers, the most common thing that I think people have outlined is that most of the people with cognitive impairment do not necessarily have just dominant pathology, which is Alzheimer's. Most of the patients who are presented in a clinic do have mixed conditions. So for the very first time, we came up with a multimodal AI framework that again takes in all these kinds of information coming in from a patient's neurology workup data, including demographics, patient level history, medications, neuropsych assessments, imaging, you name it, and then try to again go through that cascaded tier of predictions where we were trying to first assess if the person had healthy cognition, MCI, or dementia, and then if the person has some cognitive impairment, what are those etiologies that are contributing to cognitive impairment? And for the very first time, we showed that an AI framework can actually identify all those mixed pathologies that can potentially contribute to cognitive impairment. In addition to the computational aspects of things, one of the massive efforts that we try to put in is to see how these models can be validated. So what you're seeing here on the slide are three different ways we try to validate every model prediction. So the leftmost panel is basically trying to show that model predictions also align with the biomarker status of on those individuals. So for a fraction of individuals, we also had PET data, both from amyloid as well as tau. And what we are showing here is how the model predictions on Alzheimer's disease, the probability of a person having Alzheimer's increased with the likelihood of them turning out to be biomarker positive on two different cohorts. And the second column you're seeing here is on a fraction of cases again, we had access to some postmortem neuropathology data where we again showed that the model predictions align with neuropathology on those individuals. And then finally, we recruited about 12 different neurologists across the country, and we gave each one of them about 100 cases or so. And we asked exactly the same question, which is, can you perform differential diagnosis on these individuals with all the input data that even was seen by the model? And what we are showing here is that when the AI was used along with the neurologist, the predictions were about, on an average, 25% higher than only the neurologist alone. So I think that kind of really provided the first, I would say, proof or evidence that AI augmented assessments, I think, have some value. With that as the motivation, one of the things we did was we started to really think about expanding that question further into not just looking at etiologies driving dementia or cognitive impairment, but we also use the same framework to assess if we can take, again, clinical neurology workup data. So when I say clinical neurology workup data, typically not many people get a tau PET scan or an amyloid PET scan. So the question we were trying to ask was, okay, can I take again the same neurology workup data to see if we can identify who is likely to be PET positive on an amyloid scan or a tau PET scan? And the reason that was important is because as we started to work with some of these neurology clinics, the main question they were trying to ask was, how can we basically not only think about treating these patients, but perhaps even identify some of these patients for clinical trials? And the challenge that I think most of these people were having was that the clinical diagnostic criteria was not necessarily meeting the clinical trial enrollment criteria for some of these patients. And as a matter of fact, there is a neurology clinic in Arizona where we were working with, and for them, the screen failure rate was almost as high as 80% because when they were trying to screen patients just based on the clinical conditions, they were not able to get the right patients who eventually would turn out to be PET positive. So this model was directly applicable in that scenario where we were trying to use all the data that they would normally collect in a clinical setting to then predict who might turn out to be PET positive so that they could potentially screen those individuals to think about the next steps in terms of bringing them back again for a PET scan or maybe thinking about doing further assessments on those individuals. So this was basically a very nice way of thinking about creating a direct application of a multimodal AI system applicable not just for clinical management, but also for clinical trial assessments as well.
So building for
so here I'm going to show you a very short video of how we have already integrated this entire multimodal system in a EHR. Here, this is an Athena EHR system. And what you're seeing here is just a provider view where provider walks in and then they basically sees the patient data here. And then when they click on that patient data, our AI system basically has run the entire information on that patient overnight. And then it just basically provides a tiny flag, orange flag that you're seeing here on the top left of the screen. And that is basically an indication that the provider can actually take a look at this specific patient's brief report, which is highlighted based on what the AI model actually thought that this person is likely to be. And in this case, this person is actually undiagnosed. And when the provider saw this patient, they actually understood that there are some reasons why this patient was undiagnosed. And then they basically went into the details of looking at why the AI model actually flagged this individual in terms of what might likely be the cause of cognitive impairment. So as you can see here, this entire AI is actually integrated within the EHR. It's like an app and where provider-centric, very seamlessly integrated within their EHR, and it kind of provides all the details as to why the AI actually flagged this individual, what are the reasons that this was flagged, what are the factors potentially contributing to cognitive impairment, including all the etiologies that are driving cognitive impairment, and also providing an explanatory evidence that why this specific AI is actually flagging this individual. So what you're seeing here on the screen is a list of supportive and unsupportive reasons as to why the AI actually thought that this person likely needs to be brought back again into the clinic for further checkup. And as we were talking with these primary care providers, we realized that they're not necessarily just interested in predictions or assessments. They also wanted a pathway for them to automate the next steps as well. So one of the things we were trying to do is after the AI flagged that individual, we show the report as to why the AI flagged that individual. And beyond that, we're also trying to help these practitioners to select potentially the next set of tests that they could potentially do within the resources that they have. And maybe they can just click on those specific tests, move forward with that, and also understand what kind of CPT codes actually apply to those specific tests so that they can also automatically click those things. And then finally, once they are happy with the report, once they're happy with the test that they want to take on these, administer on these individuals, once they're happy with the CPT codes, they can just move forward. They can automatically create documentation, which is also AI generated. And they copy the documentation, move forward with that next step of documentation, because we want to make it very easy in terms of how these individuals or sorry, these providers can actually do these things efficiently. And finally, after the documentation is done, we are trying to give them potential ways to follow up. For example, one of the things they could do is they can call the patient or the family back again for additional testing. If they are a primary care provider, they may not have access to a neurologist. So we are trying to provide a way for them to get a teleneurology consult. And then if they want to do further things, for example, see if this person is likely to be enrolled in a specific clinical trial. We are trying to map the zip code and the patient profile and the provider interest to specific clinical trials that are happening within that region. So all these different steps that we are taking and automating within the EHR system so that the person can actually, or the provider can actually move forward, not just by taking the predictions. The goal is to actually make sure that we are helping them every step across the process so that the individual can really feel good about using AI in their practice. And the idea here, I think, is building models from the research side has been amazing for many years. I think one thing which I've realized after talking with these practicing neurologists is that they don't necessarily care about whether our models are 90% accurate or whether they can do this or that. I think the most important thing that I've learned after talking with these individuals is they need help on entire workflow, not just about making a prediction on who is likely to be cognitively impaired, but they also want to make sure that those predictions are actually helping them move forward with the daily management. I think that's kind of really one of the things we have learned, which is why we spent the last several months to really work hard to do this entire integration on EHR so that now the providers are very happy in terms of using whatever outputs or reports that we are generating, which are AI generated. Obviously, ultimately, the decision is by the provider. They are the ones who are trying to either consider the predictions on the report or not consider. So there are many cases that we have observed where the AI is actually flagging an individual, but the provider doesn't want to move forward with that AI prediction because they think that patient actually is not going to come to their clinic because for some other practical reason. So in other words, what I'm trying to say is that there is one aspect which is about AI trying to assess accurately a person's cognitive status, but there are so many other practical aspects beyond accuracy, beyond the condition of those individuals, but some aspects such as distance from the clinic to their home. Sometimes they may not get a ride, so that's why they're not actually coming back for a follow-up. So these are some of the aspects that we realized I think are actually going to drive management beyond what AI can do. And quickly, the next one I want to talk about is what we are calling as a virtual neuroradiologist for brain MRI analysis. This is basically a vision language model, very much similar to, I think, some of the foundation model discussions we had before, is trying to somewhat mimic how a radiologist reviews an MRI study and provides a report. And the reason we wanted to do this is because I work with a lot of clinics in India where there is no radiologist. For them to actually do anything with these patients, they have to wait weeks to get even some input from a radiologist, even after getting an MRI scan. So after talking with them for many, many weeks, we realized that even if we have a tool, a research tool, that could help them at least get a first pass impression on an MRI study, then I think that can make a huge difference in terms of how they actually operate how they basically operate on a daily basis. So because of that, we trained this vision language model that basically took about 850,000 brain MRI sequences, unique brain MRI sequences, and created a framework which basically exactly does the job of a radiologist. So in other words, I can show you a demo here where it's a web tool. I'm happy to provide access to it. You can securely log into it, and then a user can simply upload any sequence, any brain MRI sequence, multiple sequences at the same time, and then provide a clinical context if needed on the left side, and then simply click report. And this obviously provides a viewer for the user to see what exactly the case is. And then as the images are uploaded and the generate report button is clicked, it takes a few seconds because it's running through our computing servers at BU, and it provides basically a quick summary of the findings and a quick summary of the impression on this individual. This is very much the same as what a radiologist does on a daily basis. And on top of it, we are also provided a chatbot on the right side where if the user wants to ask additional questions beyond what they see on that summary of the findings or the impression, then they can actually ask that question, which is, for example, what is the key imaging finding? And then the same model is now run on the same case independently of what is shown on the findings and impression. And it provides basically a very quick response of the question that can be asked. And there could be any different questions that can be asked, but this is all pointing to that specific case. Thankfully, right now, many people who are currently using this, at least in India, are using this as a research tool so that they can actually get some quick outputs. It's not yet changing the clinical practice, but we are hoping to sort of really move forward with disseminating this broadly, not just within India, but across many other places. And part of that, what we recently are doing is we got a research grant from a clinical trials institute at University of Southern California, where we are planning to integrate this EHR-based AI system across 7.7 million patients across 40 different US states, where the idea is that these are all federally qualified health centers across 40 different states, catering to many different primary care facilities. They all operate through a single instance of an Epic EHR. And the idea is that we're going to integrate this AI through that Epic so that we can basically start disseminating this across many different states. And the grant that we received was mainly to understand how we can potentially identify individuals across these FQHCs on early diagnosis of cognitive impairment. This work is still in progress, but this is something that I'm really excited about because finally, I think the bottom line here is that research, I think AI is progressing massively. So many people are trying to build so many different models. One of the things that we are trying to do is no matter what we do, we have to really think about translation. And we have to really think about how to really take those additional steps beyond research so that these tools can actually get to the right user so that they can use it and then hopefully appreciate the value of AI. With that, I'm happy to take any questions.
Thank you very much, Vijay. So we do have time for questions for Dr. Kalachalama. So I'll let our moderators proceed.
Hi, Dr. Kulachalam. We have questions for you. How did your multimodal work pair antemortem and postmortem data? Is the data or model open sourced?
Yeah, so everything we have done has been open sourced. So all our codes, our models, and everything has been shared online. I'm happy to share the links if anybody is interested. And to clarify, we used antemortem data to create the models, and we used postmortem data for model validation.
Okay, thank you. And the next question is, are there any safeguard to mitigate hallucination in Remind?
We have several safeguards. I think this is still work in progress. I'm not saying this is fully fledged, non-hallucinated vision language model. We have some inference time adjustments that we're trying to do so that the model doesn't hallucinate. We are trying to work towards more efficient training paradigms to improve the model performance without hallucination. But one thing I've realized, I think this is something that the hallucination part of language models, the accuracy aspects of any machine learning model, the interpretability aspects of all these models, these are all academic exercises. I just want to emphasize that again and again. When I talk to a neurologist in a small community clinic, they don't really care about whether our model is interpretable. They don't really care whether our model is hallucinating. They just want to make sure they go home at 5 p.m. So anything that we do there, they want to make sure that it is somehow seamlessly integrated within their system. It is actually helping them do their job in a most efficient way so that they can actually go home at 5 p.m. So keeping the academic exercise aside, of course, we have to take care of ethics, hallucination, and all these things. But right now, if we solve that last mile problem of making sure that these tools are somewhat useful and letting the provider make the final call, I think we are at least making the right progress in the right direction, while also hopefully tackling all these other academic exercises.
Yeah, thank you. And the next question is, what are the required MRI sequences? Is there a minimum or high priority sequences needed for highest sensitivity?
It depends on the study. Like, for example, if somebody with Alzheimer's or dementia may get a different set of sequences for their session, whereas somebody with a brain tumor may have a different set of sequences. So our model is agnostic to the sequence type. It can take more than one, or it can even take a single sequence to process that information.
Okay. And the next question is, what are the main challenges in diagnosing mixed dementia cases and how might the performance be improved?
For the MRI or for the first work?
I think they didn't mention about any specific phenotype. So,
Yeah, well, I think we are not trying to diagnose mixed dementias using MRI. I think we are
okay.
trying to basically, I think the first work that we showed was mainly about assessing mixed dementias. The only thing I can say is the model is trying to use clinical consensus as a way to create or for training. But for validation, what we are trying to do is once the model aligns with certain neuropathologies, whether it's ABC scores or CRAD scores or TDP-43, we're trying to see which of the model predictions are actually aligning with different neuropathologies. So there is some kind of potential way to think about validating with mixed pathologies, especially because the model is trained on antemortem data with clinical consensus as the label. But the only thing we did after that was align the model predictions with mixed neuropathologies observed postmortem.
Yeah, thank you so
Very
much.